5. Medical checkups I'd never get after 65. Doctor explains. Allow me to set a scene, a scenario that unfolds with surprising frequency within our healthcare system, often without the full understanding of those it impacts most profoundly. Picture yourself at 74 years old, feeling vibrant and engaged with life. You're enjoying restful sleep, your energy levels are robust, and you're actively participating in activities that bring you joy. Your annual physical arrives, a routine checkup, nothing to raise immediate concern. Your physician, reviewing your chart, might casually suggest, you know what, just to be on the safe side, let's run a few tests. 6 weeks later, a follow-up appointment finds you in a surgeon's office. This isn't because you experienced any acute illness or felt unwell, but rather because those just-in-case tests unearthed an anomaly. This discovery, in turn, initiated a cascade of events, a medical journey for which your 74-year-old body, as it was not optimally prepared. The comfortable, fulfilling life you had been quietly enjoying undergoes a significant and often challenging alteration. This precise narrative, while perhaps unsettling, is far more common than the intricacies of our medical establishment might readily admit. And the data underpinning these situations warrants a thorough and open discussion. I am Dr. Franklin, and the purpose of this platform is singular: to empower adults over the age of 60 with a clear understanding of what current research truly signifies about their health, presented in an accessible and uncomplicated manner. The insights I will share today are not drawn from a single textbook. Rather, they are the culmination of extensive study of medical literature and a careful observation of the evidence that emerges when the healthcare system operates on what can be described as an automated setting. The unvarnished truth, often unspoken during the typical 15-minute medical appointment, is that beyond the age of 70, certain widely recommended routine medical examinations can, paradoxically, inflict more harm than benefit. This isn't a condemnation of medicine itself, but rather a recognition that the delicate balance of risk versus reward undergoes a dramatic shift as we age. Crucially, this reevaluation of risk and benefit is frequently not happening in real time, in conversation with you, the patient. Today, I intend to guide you through 5 specific medical screenings that I would personally advocate for a reevaluation of after the age of 70. I will elaborate on why the risk-benefit calculus changes so significantly, share cautionary tales observed in real patient encounters, and conclude by providing you with a series of strategic questions designed to fundamentally reshape the dynamic of your future doctor's appointments. Please remain engaged through all 5 points, as the revelation concerning the third checkup has been a point of significant surprise for many upon first hearing it. And the 5th screening is an area where individuals often lack awareness until it is, unfortunately, too late to proactively mitigate potential issues. Before we delve into the specifics, I would be genuinely interested to know where you are joining me from today. Please take a moment to share your city or country in the comments section below. I make it a point to read every single comment, as this feedback is invaluable in understanding the breadth of this community and who I am speaking with and supporting. Before we examine the 5 specific checkups, it is imperative that I introduce a foundational concept, for without it, the full significance of what I am about to convey may not be entirely grasped. I refer to this as the longevity lens. When an individual is in their 50s, the principles of screening medicine function exceptionally well. The identification of a health issue at an early stage allows for timely intervention, potentially extending healthy life by 3 decades. The investment in screening is demonstrably worthwhile. The mathematical equation is straightforward. However, this equation undergoes a profound transformation after the age of 70, influenced by 3 primary factors. Firstly, a considerable number of conditions that are identified through routine screenings in older adults will, in reality, never pose a threat to their well-being. These are often slow-growing, asymptomatic conditions, and it is highly probable that an individual will outlive them without them ever causing significant harm. Yet, once such an anomaly appears on a medical report, the healthcare system's default is not a passive observation protocol. Rather, it is a treatment-oriented pathway. Secondly, the body's inherent capacity to tolerate medical interventions diminishes with advancing age. A surgical procedure that a 55-year-old might recover from with relative ease within 2 weeks could, for a 78-year-old, necessitate months of recuperation, lead to significant complications, result in a loss of independence, or, in unfortunate circumstances, lead to more severe outcomes. Thirdly, there exists a phenomenon known as the cascade effect. A single test reveals a minor abnormality, which then prompts a follow-up diagnostic scan. This scan, in turn, may recommend a biopsy. The biopsy could then lead to a more invasive procedure. This procedure, in turn, might result in a complication. Suddenly, an individual who entered the healthcare system feeling perfectly healthy finds themselves navigating a complex and often overwhelming medical landscape, all stemming from an initial test that may not have been necessary. This is the essence of the longevity lens, and it is crucial to keep this perspective in mind as we explore each of the subsequent checkups. Before we proceed, I kindly request that you take a moment to share your name and your location. I genuinely value understanding the composition of this audience and ensuring that my message resonates with those I am striving to assist. Our first point of consideration, the routine colonoscopy beyond the age of 75, warrants a detailed examination. Let me introduce you to Dorothy, a 77-year-old retired librarian from rural Tennessee. Dorothy had previously undergone 2 colonoscopies in her 50s and 60s, both yielding entirely clear results. She had no polyps, no family history of colon cancer, and experienced no symptoms whatsoever. However, her new primary care physician, reviewing her chart, determined she was due for another examination. Dorothy, being a diligent individual, conducted her own research and harbored some reservations. Nevertheless, unwilling to appear difficult, she agreed to the procedure. The bowel preparation regimen, the necessary cleansing process undertaken the night before, placed a significant strain on her kidneys. By the following morning, she was disoriented, experiencing dizziness, and struggling to stand. Her daughter, witnessing her mother's deteriorating condition, transported her to the emergency room before she could even undergo the scheduled colonoscopy. Dorothy was severely dehydrated, and her electrolyte levels had plunged to dangerously low thresholds, placing her heart at significant risk. She remained in the hospital for 4 days, and the colonoscopy was never performed. The profound irony is that it was entirely unnecessary. The United States Preventive Services Task Force, a highly respected body that sets national guidelines for screening, officially advises against routine colonoscopy screening for average-risk adults over the age of 75. The evidence supporting this recommendation is unequivocal. After the age of 75, in the absence of symptoms, a family history of the condition, or any concerning findings from previous procedures, the potential risks associated with a colonoscopy begin to outweigh the benefits. These risks are not theoretical. Bowel perforation, a serious tear in the colon, occurs in approximately 1 in every 500 colonoscopies. While this may be a manageable surgical complication for a younger individual, for a 77-year-old, it can necessitate emergency surgery, the implementation of a colostomy bag, an extended hospital stay, and a recovery period that fundamentally alters their quality of life. Concurrently, the colon cancers that are most likely to be detected in asymptomatic older adults tend to be slow-growing. They progress at a pace such that, in many instances, they would not cause any problems within the remaining lifespan of the individual. So, what is the alternative? Instead of a routine colonoscopy, I advocate for discussing non-invasive stool-based tests with your physician, such as the Cologuard or an annual FIT test. These tests can effectively identify genuine warning signs without exposing you to the inherent procedural risks. It is important to note that if you are experiencing symptoms such as blood in your stool or unexplained changes in your bowel habits, this entirely alters the clinical picture and warrants immediate consultation with your doctor. Moving on to our second point, we address aggressive prostate-specific antigen, PSA testing, and annual mammography for individuals at low risk. It is essential to approach this subject with a degree of nuance, as it can be sensitive. I am not advocating for the complete abandonment of cancer screening. Cancer screening has demonstrably saved millions of lives and can undoubtedly contribute to preserving yours. What I am suggesting is that after the age of 75, for individuals who are at average risk and exhibit no symptoms, overly aggressive cancer screening carries a significant risk of overdiagnosis. And overdiagnosis, in turn, directly leads to overtreatment. To clarify, overdiagnosis, in plain terms, means that today's advanced imaging technologies are so sensitive that they can detect cancers that are, in a biological sense, in a state of near dormancy. These are minute, slow-growing tumors that, if left undisturbed, would never metastasize, never manifest with symptoms, and never shorten an individual's lifespan. You would, in essence, pass away with these tumors, not because of them. However, the moment a radiologist documents the presence of a malignancy, the medical machinery is activated. This often involves biopsies, referrals to specialists, and treatment decisions, all of which proceed regardless of whether the detected cancer actually poses a threat to the individual. Consider the case of Richard, a 79-year-old retired mechanic from Georgia, a man who remained sharp, independent, and continued to enjoy his weekend fishing trips. A routine PSA test revealed a slightly elevated level. A subsequent biopsy confirmed the presence of a low-grade, slow-moving prostate cancer. His urologist recommended radiation therapy, a recommendation Richard followed. Within a year of completing treatment, he began experiencing chronic fatigue, urinary issues, and a marked decline in his overall quality of life. Accounts similar to Richard's are well documented within the medical literature. These are men who, in retrospect, expressed a wish to have understood that their cancer was the type that an individual of his age would almost certainly have lived alongside rather than succumbed to. Had this knowledge been available to him earlier, it might have profoundly altered his trajectory. Furthermore, studies published in the esteemed New England Journal of Medicine have indicated that a substantial proportion of cancers identified through mammography in women over the age of 70 were, in fact, clinically insignificant. This means that the treatment offered no discernible survival benefit, but it did carry side effects. The recommended alternative strategy involves engaging in an open and honest dialogue with your physician regarding your specific risk profile. If you have a family history of cancer, possess genetic markers, or are experiencing symptoms, then screening remains a prudent course of action. However, if you are of average risk and remain asymptomatic, it is advisable to directly ask your doctor, if something is detected, what are the realistic treatment options available at my age, and what would be the typical recommendation? This specific question has been observed to fundamentally alter the nature of the ensuing medical conversation. If you are still engaged with this content and finding it beneficial, please consider typing the number 2 in the comments section. This simple act provides valuable feedback, indicating that you are actively watching and deriving value from this information. Let us now turn our attention to the third area of scrutiny, routine cardiac stress testing in the absence of symptoms. This particular recommendation often elicits surprise because, on its face, it appears entirely logical. Your physician might suggest, "You are 72 years old. Let's just ensure your heart is functioning optimally." This typically involves an exercise stress test on a treadmill or the administration of medication designed to temporarily stress the heart, with subsequent monitoring of its response. While seemingly benign and responsible, the underlying issue lies in the high false positive rates associated with cardiac stress tests in individuals who do not exhibit any symptoms. In certain demographic groups, these rates can escalate to 40% or even higher. This means that nearly half of the time, the test erroneously flags an abnormality when the heart is, in fact, functioning perfectly normally. However, the medical system cannot simply disregard a positive finding. This false alarm initiates a sequence of further investigations, frequently leading to a cardiac catheterization. A cardiac catheterization involves the insertion of a thin tube through the blood vessels, typically originating from the wrist or groin, and guided directly to the heart. This is a procedure that carries inherent risks, including bleeding, damage to the blood vessels, and the development of arrhythmias. In rare instances, it can even precipitate the very cardiac event or stroke that the initial test was intended to prevent. The situation becomes even more counterintuitive when considering the outcomes. If the catheterization reveals a partial blockage, which is a common finding in adults over 70, many of whom are asymptomatic, the individual may then be recommended for a cardiac stent. Multiple landmark clinical trials, including the highly influential ischemia trial, have demonstrated that the implantation of stents in patients with stable coronary artery disease did not significantly reduce the incidence of heart attacks or prolong life compared to management solely through medication and lifestyle modifications. To reiterate, the stent did not offer a superior outcome compared to medication alone, yet it introduced its own set of risks, and the subsequent need for lifelong blood-thinning medication carried its own set of potential bleeding complications. Consequently, an individual progresses from a state of good health through a routine test, a false alarm, a catheterization, the implantation of a stent, and a regimen of blood thinners coupled with ongoing monitoring, only to find themselves statistically no better off than someone who managed their condition with medication and a modest daily walk. The recommended alternative strategy is as follows. If you are experiencing no chest pain, no unexplained shortness of breath during exertion, and no dizziness during physical activity, then routine stress testing is essentially searching for issues within a population where such findings are prevalent, but where the interventions do not always yield improved outcomes. Instead, engage in a conversation with your physician about optimizing your modifiable risk factors. This includes managing blood pressure, cholesterol levels, blood sugar, increasing physical activity, and ensuring adequate sleep. These are the areas where the most significant and tangible health gains can be realized. Our fourth consideration is routine bone density DEXA scans, often coupled with automatic medication prescriptions. This is a topic that tends to make people uneasy when I bring it up, primarily because osteoporosis is a genuine concern, and falls in older adults can have devastating consequences. Therefore, I must proceed with caution. I am not questioning the reality of bone loss that occurs with aging. My concern lies with the often automatic and unquestioned pathway that frequently follows a DEXA scan result in patients over the age of 75. A DEXA scan is designed to detect low bone density. Subsequently, a physician may prescribe a bisphosphonate medication, such as alendronate or risdronate. Patients then take these medications for years under the assumption that they are fully protected. However, a crucial detail that is often overlooked is the association between long-term bisphosphonate use and a rare but serious condition known as atypical femoral fractures. These are spontaneous stress fractures that occur in the thigh bone, the very bone that the medication is intended to protect. These fractures can be severe and necessitate surgical intervention. Furthermore, these medications have been linked to osteonecrosis of the jaw, a condition characterized by bone deterioration in the jawbone, which is both painful and exceedingly difficult to treat. In the interim, it is important to recognize that the most effective intervention for preventing fractures in older adults, without question, is not a medication, but rather fall prevention. This encompasses a multifaceted approach, including balance training. Studies, particularly those focusing on Tai Chi, have demonstrated a reduction in fall risk by nearly 50%. Other crucial elements include identifying and eliminating tripping hazards within the home, installing grab bars in strategic locations, reviewing medications for potential side effects that might cause dizziness, ensuring regular vision checks, and maintaining an adequate intake of protein and vitamin D in the diet. These interventions have been shown to reduce fracture risk more meaningfully than any pill, and importantly, they come without any associated side effects. I am not suggesting that medication for bone health should never be considered. There are undoubtedly patients for whom it is necessary, such as those who have already experienced fractures, individuals with very low T-scores, or those with specific identified risk factors. However, for an otherwise healthy and active 74-year-old who has never sustained a fracture and is in good general health, a routine DEXA scan leading to automatic, long-term medication prescription is a decision that warrants a thorough discussion, not a foregone conclusion. A crucial question to pose to your doctor is, before we discuss medication, could we review my specific fall risk factors? And what is the actual reduction in fracture risk that this medication provides when compared to a structured fall prevention program? If you have progressed to this point and are finding value in this information, I would appreciate it if you could type the number 4 in the comments section. It serves as a simple yet effective way to indicate your continued engagement and that you are following along with the material presented. Finally, we arrive at the 5th checkup that warrants careful consideration: asymptomatic carotid artery ultrasound screening. This is a screening test that is, regrettably, seldom discussed, and based on the available research, it represents one of the most quietly significant areas where routine practice may not align with optimal patient outcomes. A carotid artery ultrasound is designed to examine the major blood vessels located in your neck, which are responsible for transporting blood to your brain. The underlying principle is straightforward. If a significant blockage is identified, surgical intervention can be employed to clear it, thereby reducing the risk of stroke. This appears to be a logical approach, does it not? However, the reality is far more intricate, and for individuals who exhibit no symptoms, the risks associated with this screening can be considerably greater than they might initially appear. The critical piece of information here is that the surgical procedure commonly used to address a carotid artery blockage, known as carotid endarterectomy, carries an inherent risk of inducing a stroke during or immediately following the procedure, typically ranging from 2% to 3%. In older adults, particularly those with coexisting health conditions, this risk can be even higher. The United States Preventive Services Task Force explicitly advises against routine carotid artery screening for adults who present with no symptoms, no transient ischemic attacks, mini-strokes, no episodes of vision loss, and no other neurological symptoms. Their comprehensive analysis concluded that, for individuals who are asymptomatic, the risks associated with surgical intervention outweigh the potential benefits. The reasoning behind this recommendation is as follows. A substantial number of individuals over the age of 70 have some degree of narrowing in their carotid arteries. This narrowing has often been present for an extended period, remaining stable and asymptomatic, without causing any discernible problems. When screening is performed, routinely, this asymptomatic narrowing is identified, and a well-intentioned surgeon may recommend corrective action. However, the surgery to address a blockage that was never symptomatic can, and in some instances does, dislodge a small piece of plaque. This dislodged plaque can then travel directly to the brain, leading to a stroke. For this particular screening, I will refrain from detailing a single case study, as the documented outcomes associated with intervening in asymptomatic individuals are too significant to be reduced to a mere anecdote. The medical literature consistently illustrates instances where individuals arrive for a routine screening appointment and subsequently find themselves on a trajectory vastly different from what they had ever envisioned, not due to the blockage that was detected, but rather because of the intervention that followed. The recommended course of action in such situations is as follows. If you are not experiencing any symptoms suggestive of a stroke or transient ischemic attack, such as sudden vision changes, facial drooping, arm weakness, or a sudden severe headache, then routine carotid ultrasound screening is generally not advisable. A far more prudent and effective investment lies in diligently managing the actual modifiable risk factors for stroke. These include high blood pressure, which is the single most significant driver of stroke, maintaining healthy blood sugar levels, ceasing smoking, effectively managing atrial fibrillation, and remaining physically active. Conversely, if you are experiencing any neurological symptoms, even those that are transient and have resolved, it is imperative to seek immediate medical evaluation, as this significantly alters the clinical landscape. I promised to equip you with a practical framework, a methodology that can be readily applied. I present to you the 5-question protocol. Every time your physician recommends a screening test, especially if you are over the age of 70 and are feeling well, I urge you to have these 5 questions prepared. Make a note of them, save them in your phone, and bring them to every appointment. Question 1. What is the false positive rate of this test for individuals in my age group? This question is designed to ascertain the likelihood that the test will generate an unnecessary follow-up investigation, even if no actual health issue is present. Question 2. If this test detects an anomaly, what are the realistic treatment options for someone my age and with my current health status? This prompts a crucial discussion focused on potential outcomes, moving beyond merely identifying a finding. Question 3. What are the procedural risks associated with any treatment we would likely pursue? This is a question that many individuals overlook, yet every medical procedure carries inherent risks, and you have a right to be informed of them up front. Question 4. What are the potential benefits and implications of monitoring this finding instead of actively treating it? For a considerable number of conditions commonly identified in older adults, a strategy of watchful waiting combined with regular monitoring is not only a legitimate but often a superior course of action. Question 5. What is the most effective non-invasive intervention for this particular condition? This is particularly relevant when considering areas like bone health, cardiovascular health, and stroke prevention, where lifestyle interventions and appropriate medication frequently demonstrate superior efficacy with significantly lower risk compared to procedural interventions. Any competent and ethical physician will welcome these questions. In fact, they will likely hold you in higher regard for posing them. Conversely, if your doctor dismisses these questions or attempts to make you feel as though you are being difficult for raising them, this provides valuable insight into whether that physician is the right fit for your healthcare needs. I wish to conclude with a fundamental distinction. There is a significant difference between medical interventions that are designed to identify findings and medical practices that are geared towards enhancing your overall well-being and quality of life. After the age of 70, the primary objective of your healthcare should not be the generation of incidental findings. Instead, it should be focused on safeguarding and extending your quality of life, preserving your independence, maintaining your energy levels, and ensuring your continued ability to engage in activities that are meaningful to you. The most accomplished physicians I have encountered possess a profound understanding that sometimes doing less requires more wisdom than doing more. Recommending watchful waiting often demands greater courage than ordering yet another scan. You possess the inherent right to understand the purpose of any given test, what the potential outcomes are if something is identified, and whether a detected finding would indeed be treated, and if that treatment would genuinely contribute to an improvement in your life. Medicine has provided us with an array of remarkable tools. However, the utility of these tools is contingent upon their application within the appropriate context, at the right time, and for the right individual. You are that individual, and you are deserving of a healthcare experience that is meticulously crafted around your personal goals, your values, and the unique characteristics of your body, rather than being dictated by a rigid checklist. If this video has offered you a novel perspective on navigating your health after the age of 70, I encourage you to subscribe to this channel. I'm committed to producing content of this nature on a weekly basis, delivering practical, evidence-based, and candid information to empower you to assume greater control over your health during these pivotal years. Furthermore, I invite you to share your experiences in the comments section below. Have you ever undergone a routine medical test that led to an unexpected outcome? Your personal account might serve as invaluable guidance for someone else preparing for their next medical appointment. Please prioritize your well-being. I look forward to connecting with you in the next video.